Okay, everybody, I think most people have logged on. I'm sure there might be a few more that'll join. But anyway, just wanted to say hi. My name is James. I am a PA. I've been practicing, well, for a long time. Let's just put it that way. I practice neurosurgery, but today we're going to be doing a virtual shadowing session with Annie Kwan, who graduated from Stanford PA Program, and she is a PA in cardiology. But I'll just go ahead and turn it over to Annie and let you run it from here.
Good evening, everyone. Thanks for joining me at dinner time Pacific side and bedtime story on the Eastern side. So just a little bit about me. I was a dietitian prior to looking into PA school, and I actually did the program along with James back in 2004. So a long time ago, and I think it's the best decision I've ever made. So I hope that's what you find when you get there. So the PA program was really rapid and intense. And when we got out, my first interview, I got lucky. I was with a group of the current group, the cardiac electrophysiology group, who was looking for their first PA. And they gave me a chance, and they said it was fine, that I was right out of school, that they wanted to mold me. And 18 years later, I'm still here. It's been the best decision. So today I'm going to go over a little bit about what cardiac electrophysiology is, and sort of what my role is in with this group. So cardiac electrophysiology, next please. What is it? So it's actually a subspecialty in cardiology. We're kind of like the electricians for the heart. We work very closely with the general cardiologists who kind of manage a patient when they come in with a cardiac complaint. We work very closely with heart failure patients, the heart failure group, sometimes the cardiac surgeons. Post surgery, they can have lots of arrhythmias. We work with the interventionalists, who are like the plumbers for the heart. So even though it's a little branch within cardiology, we work with this wide range of cardiologists. So we specifically deal with rhythms, slow and fast. And treatment for a lot of these arrhythmia problems are either going to be medications. They can be ablation, where we go in and figure out the area to fix the abnormality and basically burn the area. It can be devices for bradycardia, tachycardia arrhythmias, and a lot of our tools are going to be echocardiogram, exams, primarily the EKG. The EKG is like the picture that tells us everything, even without talking to the patient. We can look at an EKG and say, okay, we think we know what they're feeling. We think we know what the problem is. So it's super cool. When I first started, I was very intimidated by the whole EKG part, because, in school, you're just learning the very basics. But as I've been in the field and learning little nuances about it, is just so interesting and so fun. So that slide was just a little bit about the conduction system. I'm sure you guys are all of a very background, and excuse me if this is a little elementary, but the usual conduction system, we got 4 chambers in the heart, starts at the SA node, and it goes down to the AV node, which is sort of the middleman of the heart, that kind of gatekeeper of what's happening in the atria, and whether that signal is going to get down to the ventricles. And they basically then from the AV node goes down the bundle branches, the right and left bundle branches, the Purkinje fibers, which fires very rapidly to cause a ventricular contraction. And just a little slide on a 12-lead EKG, the placement of it. So these are very standard placement. You got your the limb leads with the arms and the legs. And then the leads that go across the chest, the V1 to V6, those are your precordial leads that kind of look at the heart, which tends to be a little sideways facing the left chest, kind of looking at the heart in this very wide view from front to sort of far back. So with the 12-lead EKG, it's very telling. You can localize an arrhythmia very well with a 12-lead EKG. So when you're talking to electrophysiologists, they always prefer to look at a 12-lead EKG instead of your little telemetry strip that may be only showing a couple of leads. This is the breakdown of the leads and which area, what leads you would look at to determine if it's inferior, lateral, anterior, septal. And that's all for localization of an arrhythmia. A very simple diagram of a cardiac cycle with a P wave indicating atrial contraction. And then there's a little flat line there because the signal has to travel down to the AV node, which then pass on to the Purkinje fibers, which cause the QRS, which is the ventricular contraction. And after the ventricular contraction, there's a rest point in the heart, the T wave, where the heart rests, repolarizes, and restarts the whole process again. So looking at this one cardiac cycle, all these little intervals are important in our field, and certain intervals, are considered normal, and then beyond that is abnormal. And I'm sorry, this is what I meant by my slides. I'm sorry, the titles got blocked out for some reason. So I'm gonna go through a couple of case studies highlighting some of the key things we manage here with EP. So this is a case on bradycardia. I have a 74-year-old female with depression, diabetes, bicuspid aortic valve. She's missing a little leaflet, is congenital, and she has hypertrophic cardiomyopathy. For those of you who don't know what that is, it's the middle part of your heart is thicker, the muscle is thicker, which can cause issues with flow out of the heart. So some of the athletes who die suddenly, a lot of them on autopsy has hypertrophic cardiomyopathy. She has been followed by a cardiologist since 2011, and she has finally this year progressed to severe aortic stenosis. So her aortic valve is now very stiff and does not allow the blood flow out from the chamber of the heart to the rest of the body. I have a little model here. I don't know if you could see me or not, but here's my heart model. And I got the right atria, right ventricle, left atria, left ventricle. And the aortic valve is right over here where the blood basically pumps out. So this area is very tight, so the blood does not rush out as it's supposed to. So as a result, it would make sense that the symptoms would be fatigue, shortness of breath, decreased exercise tolerance, because she's not having that blood flow that she needs and the oxygen that she needs. On exam, you would hear potentially a very loud systolic murmur because there's all this rumbling if the blood isn't getting out of that valve. Echocardiogram is a ultrasound that looks at heart function and valve structure. She does have a normal squeezing function of the heart, so her heart muscle is okay. She has this hypertrophy that we know about, and the aortic valve area is very small, very tight. Generally, in cardiology patient, they will go ahead and do a cardiac catheterization, an angiogram, looking at blood flow feeding the heart. So she has normal coronary artery disease. There's a little plaque, but nothing obstructive on the plumbing side of things. So she's being considered for a transcatheter aortic valve replacement, which is a non-invasive, minimally invasive procedure where they go through the groin, get to the left atria, and they could deploy, get to the aortic root area, and they could deploy a little valve versus a surgical aortic valve replacement. So they ultimately decided on a surgical replacement for her because of the hypertrophy of the heart. They decided that she was best served if they dealt with the valve as well as did what we call myomectomy, where they went to the septal part of the heart where the muscle is thick here and cut off a little bit of it. So they did a surgical approach instead. This is her EKG prior to the surgery, and you'll have to trust me that it's just normal sinus conduction. All the intervals are very normal. So as I said, she underwent the aortic surgical aortic valve and myomectomy. Post-procedure, she was in complete heart block. Basically, what has happened is when you're working in this area, the aortic valve right here, they cut out part of the septum for the hypertrophy. The sinus node, is on the right side, and then the conduction basically comes down the septal. So anytime a surgeon is doing something, potentially with the valve that is near the septal area, you're at high risk of causing heart block. And that's just one of the known complications. So it's not unusual that someone after a surgical procedure like this are in complete heart block. Sometimes it resolves within days, sometimes it doesn't. So they gave her a few days. In the meantime, they put in what we call temporary pacemaker to keep her heart going. And then you could turn down the pacemaker and see if she has her own rhythm, and she did not have it. So on post-op day 4, they went ahead and implanted a pacemaker. So that would be the treatment for complete heart block where the AV node is just out of order. Therefore, it doesn't communicate. It doesn't allow the top chamber to communicate with the bottom chamber. This is one of her EKG. If you're noticing that little P wave, that little bump before the big spikes, that interval now is very long. So indicating that there is some, there's some damage to that area. Here she is conducting. Some people can have also what we call intermittent conduction, where sometimes they're okay and sometimes they're in a heart block, in which case you would still put in a pacemaker, because if the heart block period is long, they have no pulse, or they have a very low pulse, like 30. So couldn't really function with that. This is just an X-ray of her pacemaker. They're quite small. And then she has 2 leads to communicate with the atria and the ventricle. There's that little horizontal bar you see across the chest. I think that's the tissue valve are usually not visible. So I'm not really sure why I see that, but that would make sense that that's what that is. And then on this X-ray, you also see that the surgeon patched her back up, and she has all these sternal wires that's holding her sternum together. This is a sample of a pacemaker generator. That's the brain of the device with the battery and the computer chip. They're very small these days. They're like the size of the face of an Apple Watch. The leads can come with where they're screwed in, or where they got these tiny little barbs that kind of hold on to these muscle that's within the heart. And they're very small. They're very thin and small, and they're wrapped in silicone and flexible. So post pacemaker, they normally do an EKG. They did not do one in her case. This is a pace rhythm. You see those big giant spikes, but this is a unipolar pacing. This is still an EKG of her when she had the temporary wire, which you tend to see these big gigantic spikes on the EKG. Her regular pacemaker look, you would see a much smaller spike right in front of the EKG, and that's usually visible. So to wrap that up, that was bradycardia. So when someone has bradycardia, you have to think, is it drug related? If it's drug related, could they do without that drug? And if you withdraw the drug, do they resume normal conduction? And if they do, that might be it. It can certainly be related to age. As we all age, things get fibrosed, they don't work as well. So someone older can progress to complete heart block needing a pacemaker. It could be trauma to the area, in this case, surgical trauma. There are some rare, congenital diseases where people are born with congenital heart block. The next case is I'm sorry, the title is kind of all blacked out. I tried to audit that, but wasn't very good at it. So the next case is supraventricular tachycardia, what we call SVT, another very common thing we see in EP. It's basically a fast rhythm in the top chamber of the heart. It's not dangerous, but it's a nuisance. People have it. It could be very rapid, can go for minutes to hours, and it scares people. They don't know what to do. They don't know should they go in, should they call, emergency. So it really affects their lifestyle. So I have a 47-year-old female with history of diabetes, hypertension. She's been complaining of intermittent palpitations for years, for minutes. They were never able to capture it. They've done event monitors. They try to do EKG. She's been to ED when she had the symptoms, but sure enough, Murphy's Law, you go in there, it stopped. It's all good. She says that these palpitations are associated with rapid heartbeats, cause her dizziness, and she feels like she can't catch her breath. So finally, recently, right around Thanksgiving, she had one of these episodes while she was shopping. And this time it lasted over an hour. So she decided to go to emergency room. And I'll show you in a minute her EKG, but the treatment for these tachycardia, when you go into emergency room, or if you call 911 and the EMT comes, they will try to give you, if it looks like SVT, they'll try to give you adenosine, which is a very immediate medication. It feels horrible. It literally is stopping your heart for a few seconds and allowing your normal rhythm to resume. So that's one of the quick medicine you can use. Other times, they choose to use, give people a little IV beta blocker, little IV calcium channel blocker to kind of stop the rhythm when they're in emergency room. But long-term wise, those can be treatments too. You can take the oral form of it. You can be considered for a cardiac ablation. So this is her fast rhythm. It's quite fast. It's within 2 boxes. So it's definitely faster than 150. It's probably in the range of like 180 beats per minute. There's a very specific look in SVT. All the axes, all the 12 lead axes should still look like their baseline EKG axes, but you're not going to see the P waves. The P waves are signifying sinus rhythm. They're not in sinus rhythm, so you're not going to see the P wave. The P waves are sometimes hidden within these QRSs, but we can see that it's very fast, and not going to go into the details, but EP can actually tell what type of SVT it is. So the nice thing about cardiac ablation over medication is if we can trigger it the day that the patient is here, which is most of the time, we can actually cure it by ablation. We basically figure out where it's coming from, get there. We use heat, and just a few seconds of burning the cardiac tissue, you can destroy the tiny little area that's firing. So in the study, it's a lot of, inducing the arrhythmia, tracking where it is, mapping to where it is, burning, testing, sort of a cycle of that. And the good endpoint would be that you have lots of SVT in the beginning of the case, and towards the end of the case, you no longer can bring on SVT. So that's how you know you got it. And success rate, depending on the type of SVT, can be 80 to 90%. They never have it again, and they don't need to take medication. So it's very satisfying for the physician. It's very satisfying for the patient that they no longer have to deal with this. This is just a picture of, some of our catheter placement within the heart, and where we would go to ablate. This is just a picture online, but this is what the EP lab looks like. It's quite high tech. We're mostly doing these procedures through the femoral vein at the groin site, and we are able to get into the heart. There's 3D mapping involved that can hone in on the spot, and then they're looking at live streams of electrical signals that are just flying by. And the doctors are very good at recognizing patterns. They recognize a change in pattern. They look for very small little clues with that, and that kind of tells them where everything is. Once in a while, we will use intracardiac ultrasound along with the procedure. And they're very easy for the patient. So when we're all done, all the equipment gets removed, and they do have a long bed rest, and mostly just caring for the groin site, the entry site, to ensure that there's no bleeding. Cardiac arrest, a more serious arrhythmia that we also deal with. So we kind of, EP is very nice because it's a nice balance of happy cases where you could cure things, where you give them a pacemaker and they feel so much better. And then we deal with another population which have cardiomyopathy, very weak hearts for a lot of reasons, cardiac arrest, people dying and surviving it. And we're seeing the ones who make it. So this is a cardiac arrest case. She's a 58-year-old female with history of multiple myeloma and had chemotherapy. And chemotherapy is a toxin. So that's some of the people who undergo chemotherapy, depending on their regimen, do end up with cardiomyopathy, which basically is a weaker heart muscle. And so it doesn't pump all the blood that they need to their heart. So they're very weak. They have lots of heart failure symptoms, not a lot of energy, can sometimes be quite debilitated from it. One of the main therapy for cardiomyopathy is the medication that keeps the blood pressure low, keeps the resistance in the blood vessel low, so that their heart doesn't have to work very hard against high pressure. Echocardiogram is something we get, ultrasound to look at the heart function, and the ejection fraction is low at 38%. A normal ejection fraction is 55% and above. Global hypokinesis just means that the whole chamber of the heart, there's not one particular part that squeezes better. It's just all generally not squeezing very well. We always look at their arteries because we want to see, is that the reason for their cardiomyopathy? In her case, that's not the reason. In the world, mostly that is the reason for cardiomyopathy, but her case is because of the chemotherapy. So on November 4th, she was watching TV, and luckily she was with family members. She suddenly went unresponsive, and they heard this just sort of gurgly, loud noise. They called 911, who taught them how to do CPR. EMS arrive, and they do advanced cardiac life-saving measures. She had to be shocked 5 times before they can get a rhythm. And when they bring her to the hospital, if it's such a down long time, they go through something called hypothermia protocol. They cool them for 36, 48 hours, quite cold. And that has been shown to really help with their neurologic status. When I first started in 2004, there were many sad cases where cardiac arrest survivor, if their arrest was more than 6-10 minutes, they had significant neurologic sequelae. Nowadays, with hypothermia protocol, it's amazing. I've seen people with a long code, like 20-minute code. They're totally okay. They don't remember the time frame of the cardiac arrest because you lose sort of that short-term memory with the cardiac arrest, but they're able to form new memories. They can, they're functioning very neurologically. They're very normal. So hypothermia protocol has been amazing. Treatment, when you have a cardiac arrest and you survive it, and there's no cause to explain the cardiac arrest, no reversible cause, what we offer patient is a implantable cardioverter defibrillator. So an implanted defibrillator, once you've had a cardiac arrest, there's a 30% chance that you will have another event somewhere down the road. So having a ICD implanted is basically like a paramedic is with you all the time and watching out for your heart rhythm. So if she was to have another cardiac arrest, within 10 seconds, her implantable defibrillator will deliver shock, saves her life. There's unfortunately no drug that would treat cardiac arrest. Very, very ugly rhythm, chaotic, fast. It's like within a box or less, it's like 300 beats per minute. So not a survivable rhythm. If she was alone, that would have been end of the story. Her EKG, her baseline EKG, after her rest, is sinus rhythm. She has some conduction issues. She has something called left bundle branch block. So one of the signals going down to her left side, she has an electrical block. She has these big QRS that tells us she has PVC. So there might be a spot in her heart that's kind of irritable at the minute. And she got implanted with what we call single chamber defibrillator. A defibrillator is the generator of it is a lot larger because it delivers a big shock to the heart to stop the chaos. And the joules that's delivered is around 40 joules. So it's equivalent to like 900 volts. So it's a huge amount of energy. It requires a much larger battery. So therefore the generator of a defibrillator is a bit bigger. I think this one is Afib. Sorry, I can't see my title there. I apologize for that. Afib, I cannot do this without talking about Afib because Afib is the most common abnormal rhythm out there. You might even, over the holidays, if you talk to uncles, aunts, whatnot, they might say, oh yeah, I have Afib. It's just very common. Luckily, it's not a fatal or dangerous rhythm. It could be a very annoying rhythm. Some patients have no symptoms. Some patients are very symptomatic. Obviously, we're seeing the very symptomatic patients. A 70-year-old male with obstructive sleep apnea, prostate cancer, hypertension, Afib. He has palpitations about several times a week, lasting 1 to 5 hours. He feels the rapid heartbeat. He gets lightheaded because the blood flow isn't as great. And he finds that he has a lot of trouble focusing with his eyes. Echocardiogram, normal pump function, no valvular disease, and normal size left atria. So those are all good because someone with, AFib and a bad heart kind of goes together. So the more AFib you have, the heart can get worse. But if you have a bad heart, the more likelihood you have AFib. So it's kind of like this chicken and egg of which came first. And in individuals who have bad hearts, they're not necessarily a great candidate for an ablation for AFib because their heart has remodeled, they're stretching. The ablation is not likely to get them a high success. So we're looking for a population with normal heart, no valvular disease, normal size, which tells us that they're in their early phase of AFib and that the ablation could be helpful. Treatment for AFib is rate control. A lot of times when people are going to AFib, they can go very rapidly, especially if they're young or have good AV node conduction. So AFib is when your top heart is just quivering and all this chaotic rhythm. The top chamber of the heart can be going 300 beats per minute. But the AV node is very smart. It's designed to not let 300 beats go down to your ventricle. Otherwise, that could be death. So the AV node, the gatekeeper, may let some of the signal through, but not all of it. So you could end up with your ventricular rate being like 150, but not 300. Right. So at 150, you don't feel great because your heart is just racing. You're not doing anything. You're sitting here and it's going on for hours. So if you can rate control, if you can give someone lots of medication and slow down their ventricular rate to like maybe 60, 70, they may not even know they're in AFib when their rate is controlled. So rate control is one of the strategy. Rhythm control is when you aim at trying to keep them in normal rhythm versus AFib and control rate. And most people will try for rhythm control because your heart is just going to be happier when the atria and the ventricle are synchronized and going 1-to-1. It's overall better for your heart. So most people will try rhythm control first. The third thing about AFib is stroke prevention is very important. When you're in AFib, again, your atria is just vibrating. So the blood that it receives, it's not getting pumped completely down to the ventricle. It's kind of floating in there, stagnating, which can form clots. So if that gets pushed out, that can equate to a stroke. So being on a blood thinning and preventing, sort of the coagulating of the blood would be an important part of managing AFib. Some of the common medication, there are rate control medication, then there's drugs that keeps people in normal rhythm called antiarrhythmic drug. So this particular male is on diltiazem, flecainide, warfarin, which is a blood thinner. So very common medication for AFib. And he's referred to us to see if he's a good candidate for an ablation. So this is an Afib rhythm. The hallmark of Afib is it's an irregular rhythm. So if you look at it, and the QRSs are all over the place. There does not look like there's a pattern. You don't see a clear P wave or you see too many P waves. That's your Afib rhythm. This is just a pictorial diagram of what we do in terms of fixing Afib. So Afib is actually mostly coming from the left atria, and it's coming from those 4 holes that you see on that on the right side of the screen. Those are the pulmonary veins where they bring oxygenated blood back to the atria. And right at the mouth of these veins, that's where a lot of those starters for Afib are. And the theory behind this is embryologically, you got a group of conduction cells. And then as the heart morphs into 4-chamber, unfortunately, some of these cells got dispersed into area where it shouldn't have conducting cells. So that's the belief behind this. This is one of the area we know that causes AFib. So what we do is we target that area. So again, we go through the groin. We do have to make a puncture between the atria to get over to the left side of the heart. And basically what we do is we burn around the mouth of these pulmonary veins, creating lesions. And over a few months, hopefully their body will form a nice uniform ring of scar tissue around the pulmonary veins, and that acts as the electrical fence. So you could be firing in the pulmonary veins, but if it cannot cross over the ring of scar tissue, then the atria will not go into AFib. So that's one of the procedures we do for AFib. Unfortunately, it's not a cure. It can decrease somebody's AFib burden by 70%, but it's not a cure because AFib is very complex. It's more than beyond the pulmonary veins. There could be atrial stretch. There could be valve issues. There could be age. They're seeing association with obesity, with diabetes, with hypertension, basically any chronic disease that causes more stress, more pressure to the heart can cause fibrosis, malfunctioning of cells. So at this moment, there's no cure for AFib, but this is one of the procedure we offer. And it's huge. There's so much AFib out there. I think it's like 50% of what we do every day. And this is, again, a pictorial. We have 3D mapping, 3D imaging, and those are the pulmonary veins. And we basically are burning a big ring of circle around the pulmonary veins. Again, this is a picture of the EP lab, which has, many monitors for rhythm, X-ray, ultrasound, lots of equipment, lots of wiring in the room. It's a very high-tech field. Since I've been in it for 18 years, there's been so much more advances. So more to come in the next, in the future. And lastly, I cannot end this talk without talking a little bit about MI, because wherever you end up, whether it be primary care, ED, wherever, at some point, surgical field, you're still going to get probably a pre-op EKG on someone. And so there's just some key things that you want to identify that this person is not safe for whatever surgery, or you need to send them to ED. So even though we personally don't deal with MIs and our colleagues, the interventionalists, the plumbers do, we should all recognize ST elevation, acute MI. And it's not going to be, across all 12 leads, right? Because if you're having an MI in the heart, it would be one blood vessel being blocked or whatnot. And so whichever area that vessel is feeding, this may be the area that's unhappy, and this may be the area where you're having the acute MI. So on the EKG, wherever the ST elevation is, that correlates to that part of the heart. So if you're seeing ST elevation across the whole heart, that doesn't make a lot of sense. I mean, people can have multi-vessel blockages, but typically when they're having an acute MI, it's going to be one main vessel that's currently 99% blocked and causing significant issue, right? It would be very odd for all their vessel to be 99% blocked and causing an active issue right now. So on EKG, you'll just see one section where it makes sense that there's ST elevation. If you see ST elevation across all of them, it's usually what we call pericarditis, where they may have an inflammation in the lining of the heart, and therefore the whole heart is unhappy. Wherever you look, there's ST elevation. If you don't recognize ST elevation, on the right side of the screen, it's just a little diagram that shows you, where we consider the baseline. And so when you see an elevation from the baseline or a significant depression from the baseline, that's what we're calling abnormalities, whether it's an elevation or a depression. And it's got a clear, very acute MI will have that, what we call the tombstone look. So if you see a tombstone on your EKG, and that person needs to go ED or somewhere, emergent, cath lab. So I couldn't end this talk without showing ST elevation. I think that's the end of my talk.
Okay, well, Annie, thank you. Now, just if anybody has any questions, which they look like they're starting to come in. So Maddie, if you want to
Yeah, it looks like
Matt, if you want to introduce yourself real quick too.
Yes, hi everyone. I'm Madeline Terranova. I'm a PA student in January, and James helped me with a lot of my journey, and he was super helpful to me. And it's lovely to meet Miss Annie and hear all about
Where are you going?
Fairleigh Dickinson in New Jersey, where I'm from.
Congratulations.
Very excited, guys. It looks like someone has a double header question. What were your thoughts about the Stanford PA program? And then there is a follow-up question to that as well.
Sure. The Stanford PA program is very different these days than when James and I went. When James and I went, it was a very abbreviated program, 15 months. They were looking for candidates who had been working for a while, had experience, because it was a very abbreviated program. If I remember correctly, the didactic was 6 months of it, and the rest of it was all clinical, which was good. But you had to know your didactic, and so it was very helpful if you had years of experience in healthcare field, because you could pick that up much faster. You're like, oh, pulmonary fibrosis. Oh, I've heard of that. I know what that is, right? Whereas if you're new and you're studying the whole thing, it was a lot. So it was good. It got, it got the job done. It was a little stressful at times, but I'm happy with it. And, the people that I met were amazing. These were all people who did very well because, again, they had lots of experience. And I think we all passed. We all ended up at, finding a job right away. So nowadays, I think it's like there's like 2 tracks, right? There's like a PhD track. I think there's a more research track and there's a more clinical track. And it's a much longer program with, I think, a master attached to it. We've had some patients rotate over with me, so it's much different these days. I can't speak to what it is now. The student seems happy. The students who rotate through seems really happy with it.
That's amazing. That's amazing. And then the second part of that person's question is your patient population primarily geriatrics?
Oh, great question. So no, that's the fun part about EP. So a lot of the SVTs are actually, some of them, a common one called WPW syndrome. Yeah, very good. You're on your way, Maddie. They are young patients. Sometimes they have had these since they were 8 years old. We do adults. So if you're 100 pounds, we'll do you. So we have done kids that are like 12 and 13. So we have the young patient for SVT, but we've seen SVT up to 80-year-old. And then our cardiomyopathy patient can vary a bit too, because if it's the cancer population, if they got weak hearts from drug use, alcohol abuse, they could be young. And then they can we certainly have older patients too. But yeah, it's kind of a nice variety.
Very nice. Very nice. Someone's asking, when would you recommend a cardioversion over an ablation?
Oh, great question. So so cardioversion just treats it at the moment, right? That's it. That's all it does. Doesn't prevent it from coming back. Doesn't, So if someone gone into AFib and they're stuck in it and they don't feel good, then cardioversion should be considered. If drugs cannot terminate it and convert it, then it should be considered because they're symptomatic and they don't feel good. And you don't want someone's heart going at 150 for weeks and months because it can weaken their heart. So then a cardioversion is appropriate. After having a cardioversion doesn't mean you can't then be considered for an ablation. But I would say for AFib ablation, just because it's a little bit more invasive and there's not a cure. Personally, if it was me or I was giving advice to a patient, if it's their first AFib, I would recommend probably trying some medication and giving it more time to see what your AFib burden is before committing to, a risky procedure that may not offer you a cure.
Great. It looks like someone's asking, do you need a PhD to be able to perform cardiac surgeries?
A PhD?
The person asked a PhD.
Oh, no. So our colleagues, the cardiac surgeons they have about 5 PAs, And no, I've known one who did a extra residency after PA school and did an extra residency with a cardiac surgeon and learned to do vein grafts and things like that. But I believe a lot of them, a lot of them are just trained on the job, and you learn on the job. So I don't, just depends on what that cardiac surgeon wants and how busy their practice is. And do they want someone to just jump on and do the job, or are they willing to train a little?
It's awesome. They also said, thank you so much. It was very informative.
Oh, great.
What is your favorite part about being a PA in cardiology, or being a PA in general?
Yeah, there is so much. I think I'm like grateful every day that I made this decision. I really enjoy working with patients and, helping them understand their disease. Sometimes, like I said, is very happy. I go out there, I'm like, we cured it. That's it. And then, then you've got these sad ones who have some rare disease where, they constantly are at risk for dangerous heart rhythm, and they're getting shocked periodically, and learning to live with that life and kind of supporting them through that, emotionally too, not just medically, but emotionally. So I really enjoy working with patients. And because I've been in the group for a long time, I've done many different roles. So for many years, I've covered inpatient. So at Kaiser in California is a little different. We're kind of the specialty center, and we manage. So basically every Kaiser, 15 Kaiser that have rhythm problem, they all come to us. So I do a lot of admission, discharge. Sometimes I manage outpatient. I'm in clinic doing the consultation. I've been in procedures. And so I've been able to be in all aspect of it. And it's kind of a nice variety.
What influenced you to practice specifically in cardiology? This was going to be my question.
When I got out of school, it'll be interesting to hear what James says. When I got out of school, the only thing I could not do and did not want to do was GYN. I was like, not good at it. And you have to know what you're not good at and what you don't want to do. And I knew I really liked the acute care setting. I really liked being in the hospital and having more that instant results, like, what are we going to do? And I just got lucky. I put my resume out, and this was the first group that wanted an interview. And I remember them saying, oh, okay, well, do you want an interview with, cardiac electrophysiology? I'm like, I don't even know what that is. What does that mean? And so I had to look it up, and I was freaking out thinking they were going to test me on EKG during my interview. But no, they were very nice. So I just kind of ended up in here, and been very happy.
Amazing. And then they also asked, was cardiology always a specialty you gravitated towards, or did your interest develop throughout PA school?
No, PA school was quite abbreviated, and we had to do, very set rotations, right? It might be different these days because I think the programs are longer and you do a lot more rotations. But at that time, we had to do core rotation, which was, internal medicine, primary care, pediatric, OBGYN. You had a surgery rotation. It was quite limited at the time. So I actually did not get cardiology exposure at all. And so kind of just learned on the job. But the heart is a very interesting organ. So it's, it's been fun and interesting.
Awesome. What are your thoughts on the COVID-19 vaccine supposedly causing myocarditis? Have you seen any of this?
We have not seen a lot. We have not seen a lot based on just vaccination. However, I think it's still too early to know, but we have certainly seen people with, not a lot, but people with COVID, and then within the month of their COVID, they develop heart block or they develop cardiomyopathy. So in those patients, especially if they've had a cardiac arrest, we've been getting cardiac MRIs on them to try to determine if it's myocarditis. If it's myocarditis and it could be reversible, we don't necessarily want to commit this person for the rest of their life to a permanent, defibrillator. So there are things where it's like a external wearable defibrillator. So in those patients, some have gotten it because their myocarditis did not necessarily reverse within the 3 months that we were looking at it. And so you have to assume that it's long-term, right? Or going to be long-term. While a few, they did reverse and they did not need the permanent device. But no, a lot of patients are coming in saying, I didn't have this arrhythmia until I had COVID. So I don't know. It may be a little too soon to know whether it's really the cause of all of these arrhythmias.
Research papers to come. What hours do you work and are you ever on call?
So while I was working in the hospital, it never stopped. It was like 7 a.m. there, and I left at 8 p.m. at night. And I don't know, I did that for like 17 years. And it's okay. I got used to it. That's my thing. And I work 3 days in a week type of thing. But recently I moved to clinic and I'm kind of working more 9 to 5 hours.
Awesome. And then someone else asked, why did you choose PA and not MD?
I was older when I made that decision. You know, I had already, I knew I wanted to be in healthcare and I thought I wanted to be in nutrition. And when I was in that, it felt really limited. So I was older and I had met a PA at work that was just amazing. And so I thought that's what I want to do. And it made sense at my age to not have gone through the whole, you know, MD residency, all of that. I think for the audience that out there, I still say this to younger people. If you think you want to go that track, I think you should go for it. You know, the whole MD thing. But you know, it's a long commitment. So, you know, you have to kind of start young. It's a little harder when you start older.
Yeah.
And no, I don't have to be on call. Sorry, I missed that question. My service decided that we don't have to be on call and no weekends. So yeah, we're Monday through Fridays, and then the doctors take the call.
Like, are there any aspects of working in a hospital that you've noticed you miss that you're working in a clinic now?
Yes, so I don't get as many procedure days, and I don't get to see the patient face to face because our system is where we see patients from a huge wide range of area. Even before the pandemic, our clinic was always a virtual clinic. So we had done that before the pandemic. So in clinic, it feels a little lonely. Like I talk to the patient, but I don't necessarily, some of them are video visits, some of them are phone visit. So sometimes I don't feel like I meet them. And you have to know how to make a better connection, right, on the phone with someone. Whereas in person is very easy because you've got your facial expression and all that. So I miss a little bit of that direct connection, but I certainly miss the procedure part of things, you know, and being really hands-on.
Awesome. Have you ever considered switching specialties? I
have not, because I've loved the group. I have loved the doctors I work with. The ones that I started out with have actually all retired, and I'm on my new group of doctors, but they're all like wonderful people. I think to be in EP, you have to be quite patient because sometimes you're just waiting forever for that abnormal signal. So by nature, these individuals are very patient people and very calm, very nice. And I've just been very happy with the groups. I haven't thought of switching.
What is your role during a procedure?
Yeah, great question. So I think you'll find it's up to your supervising physician. So we've had EP fellows for a long time. And so they're very used to letting and guiding the EP fellows. So when I joined, the doctors were very open to saying, hey, what do you want to do? And so I started off slowly with putting in, cardiac catheters. And then it got to a point where they said, okay, I'll just stand next to you and guide you through it. Like, you know, do you want to do the ablation? So I've done that always with a physician. But through the years, I have learned to implant pacemaker and defibrillator independently. So they're in the room, but I'm pretty much doing the whole thing.
I think, Annie, what I forgot to bring up is, how about if you just tell us like what a normal day is like for you?
Great. Yeah. So when I was in the hospital, I show up and we have what we call outpatient and inpatient service. So if I'm covering the outpatient service, that's all the patients that's coming in for a procedure that day. And that could be, 5 to 9, depending on the complexity of the procedure. So my job that day would be responsible to see them, do their H&P, do their exam, make sure they're ready to go for the procedure, consent them for the procedure. If you have time, you're always welcome to go in and join in on the procedure. And then I'm responsible for, setting up their discharge, going over things with them post-care. And then when they walk out the door, the clinic person takes care of it if they have questions. When I'm in the inpatient role, I am managing a lot of people who are transferring into our hospital for the procedure. Same thing, H&P, setting them up, talking to their family, consenting them, and discharging them or transferring them back to their facility. And inpatient service will also have consults. Patients who landed up here with arrhythmia problems will do consultation to see, whether they need medication, whether they need a procedure. Then my clinic role is more consultation with new patients whom I'm talking to about procedure as an option, and helping them make that decision, and answering phone calls that comes in, clinical questions.
Well, like I know when I did inpatient, how many patients would you say you managed on a daily basis in the hospital setting?
Yeah, so it doesn't sound like a lot, but because we are our own service, like you manage all of it, right? If they have diabetes issue, if they have contrast neuropathy issue, you manage all of it. So on a busy day, I might have 8 that I own, and then there's going to be like, maybe 6 consults that I'm seeing on the side, and then there could be like 2 transfers that I'm expecting in.
Now, what was, I guess, like, I know you've kind of probably touched on, but like the typical patient that you would treat inpatient.
Oh, yeah. So very commonly, they could be post-surgical patients, again, with heart block, with VT, VF, with, AFib, or somebody just came in and, are found to have any kind of conduction abnormality, and you're trying to piece together the story of, is it because they have long-term, weak heart, or is it all new things? Do they have a family history? And you're just trying to piece it all together.
So to kind of go back, not to what you were doing, but just to talk a little bit about the PA application side of things. Now, you and I had talked about this before, and it's just something I would try to emphasize to students that I talk to. I hear a lot about how students want to become a PA because at least what they've read or been told that there's this better work-life balance, sort of intimating that maybe we don't work as long or hard as the doctor. So what do you think about that?
So if you love your physician, you're actually the one doing a lot more work than the physician. So, and I suppose every physician in every clinic or every specialty is different. But when I started, because I was the first PA, they're like, "What can you do for us?" I said, "I'm going to make your life easy." And I kept up with that. So I show them that, look, I can round before you round. And I will see all the patients. When you're done with your procedure, you could just leave. I will call the patient's family. I will see the patient. I will send them home. And as a result, my hours are like, 7 to 8. But, in that, I developed a really nice relationship with all my physician, and they're very trusting, and they're always like, "Oh, okay, Vanny's there. She could take care of it." So yeah, so I don't, I think if you want that work-life balance, they respect. So my physician respects us and loves all that, but they don't expect it, so when we say, "I got to go today," they understand and they're happy to step in. So I think, work-life balance, you have to create that for yourself, you have to set some boundaries, because you'll find that you get into that habit. And then now all of a sudden it's so comfortable. So you just do it. You just take care of it because you always do it. So they forget, they walk away, and you're like, "Okay, I guess I'm doing it," which is fine, right? You have that relationship with your physician. But yeah, you want to create that healthy balance for yourself and say, I got to leave at 6 because I have to be responsible for my child or whatnot, and, give yourself that time too. And because, your career is going to be whatever, 20, 25, 30 years long. So you got to last that whole time and not feel burnt out.
It's funny you mentioned rounding and them getting used to things. My doctor, so the policy at the hospital was the doctor couldn't go more than 24 hours without seeing the patient. So I go in and round, but generally I would go round like you. I'd go early in the morning because I got to get to clinic. And invariably, my doctor would come in as I'm leaving the hospital, and he's like, "Oh, did you round on everybody?" Like this is a mystery. Of course I did. And then he'd like, "Well, I'm just gonna go pop in and say hi," which means he's gonna go put his name on every note, which means I can go back tomorrow.
Yeah.
And this was like our routine. We'd pass each other in the parking lot. "Oh, did you see everybody?" Like, come on, are we gonna play this?
Well, but it's amazing. Like, you'll see the patients, because that's what we do too, right? We round, we talk to the patient, we went over all of it, and the doctor comes in and said, "Oh, hi, I'm Dr. blah blah." And so, you have any questions? No. Okay, great to meet you. And then they walk out, but the patients still feel that they got everything they need. They always, when the physician walks in, they always say, "Oh, she has explained all of it." And so, I don't think the patient got shortchanged. So
No,
that's the important part.
no, but I think the bigger thing I'm always trying to impress upon the students who are going into this is it's not an easier caseload. I mean, you're going to work long hours. You're going to see basically the same patients that the doctor's seen. So in terms of a work-life balance, I mean, yeah, yes, it's what you make out of it, but this is not this, you're not working any less. So don't go into PA thinking, well, this is just going to be a lesser role. It's the same role as the physicians hold. So
If a PA were to receive a PhD in PA studies, what opportunities would open?
I don't know any. I think one in our facility might be working on it, but I'm sure it could be research, it could be teaching, it could be administrator possibly. Um, I mean, I don't think more education ever hurts,
Yeah.
but I think if you're going to pursue all that, you have to know, are you the type that wants to do hands-on clinical? I think if you want to do hands-on clinical, I don't think you need to spend all these years on PhD. That's just my personal thing. But if your goal is to be administrator, teaching, broader picture, research, then I think it's worth the time. Any thoughts, James?
No, I'd agree. If your plan, as years go on and you want to get back into academia, maybe you want to be a program director, or as you mentioned, research. But if you're thinking PhD to enhance your clinical role, that's not going to change. I mean, the PhD is not going to advance your role as a clinician. And back to something you said earlier, I kind of smiled about it. It really has so much more to do with the provider, the supervising physician that you work with, and what they're willing to allow you to do. And part of that too is your initiative. I mean, if you show the initiative, I can't even think of a doctor I've ever worked with that didn't allow me to do more, as long as I showed the willingness to do it or the interest to do it. But the PhD is not going to drive that. It's just your interest in what you're doing and the person that you work with, and that bond, that relationship you have with that person.
Absolutely.
I work with a new supervising physician. I think we did 4 surgeries on our first day. And by the second or third one, he just handed me the instrumentation. He goes, "Do you want to do this?" Because he knew somebody I'd worked with. And so that's why we started working together. But I guess, after a couple cases together, he's like, "Okay." Then just halfway through, he just handed the stuff over. He goes, "You want to do the rest?" Like, okay, sure.
See, it's not less work.
No, it's definitely
He's
not
going to
less
sit
work.
down, but it's fun, right?
It is fun. It is a lot of fun. And again, if it's people that you enjoy working with, it is a great career. So I think we'll take one more because I think we're a little bit past the time, but Maddie, is there one more?
How long after being hired did you start seeing patients by yourself? What did your initial training look like?
Yeah, so I was directly trained by the physicians, and I took the initiative. After a few weeks on the job, I went home, read a lot about EP, trying to learn as much and absorb as much as I can. And I decided, at that time we dealt with a lot of devices where you have to go check them post-surgery. I decided just take the initiative, got there early round, saw them myself. And by the time the physician come in, I would just go over it with them, and they double check. And I think they appreciated that and saw the saw the willingness, and then from there they were comfortable letting me do more and see more. And and I think it's okay when you go see a patient and you don't have all the answers, you could be honest and say, you know what, I'm going to check that with my physician and I'll come back and let you know. Patients, they don't expect you to know all the answers. And if anything, you still know more than most patients. I know there's Dr. Google now, but for the most part, you still know more than the patient. And it's okay to say, I don't know. But I can get back to you with that.
Okay, well, I'm sorry to cut it off. I know there are a couple more questions, but we're a little bit past the time. And I want to thank Annie for giving us your time tonight. And I have to admit, I mean, I'm sure we all learned something. I didn't know about that hypothermia treatment, especially reducing the risk of neurological injury.
It's amazing.
Yeah, it sounds like it. I want to talk to one of my doctors, and I have not heard that before. That's fascinating. But thank you very much for your time. I appreciate it. It was really fantastic, everything you shared with us. I'm sure everybody appreciated it. Thanks, Maddie, for your time.
Yes, thank you so much, Annie, for all the info and
Thanks,
everything.
Maddie. Thank you, James, for this opportunity. And I wish everyone out there lots of luck in your journey. And I think you'll find it very rewarding.